All right. Hi everyone. I have to say it's a great conference and great pleasure to get the chance to present here. So, okay, the use of TACK in the vascular system in treating complex CTO of the SFA. Primary operator is Dr. Shammas from Midwest Cardiovascular Research Foundation in Davenport, Iowa, and I'm presenting the case here. All right, so I have no conflicts to disclose. The history of present illness, 55-year-old gentleman with dyslipidemia, peripheral artery disease. He's a smoker. He also enjoys 6 packs of beer daily. He presents with the chief complaint of rest pain over his left lower extremity. Prior to presenting, he had a CTA that showed multi-level disease involving the bilateral iliacs, left common femoral artery, had severe disease, almost 80%, and he had a CTO over the distal SFA. On exam, he had a weak pulse over the left side. Over the left lower extremity, his distal pulses DP and PD barely palpable, and he had a healed ulcer over his left toe. He's on aspirin, statin, ramipril. Also, I found Chantix and ibuprofen on his medication list. Here is his baseline angiogram. So I don't have images from the iliacs, unfortunately, but you can appreciate from the severity of the calcifications, you can almost see the SFA without even contrast injection. There is severe disease over the distal POP region, almost a CTO. It reconstitutes distally to 3 runoffs. The flow over the collaterals is actually much better than the flow over the tibial vessels. And so at this point, we decided to proceed with an antegrade approach. We upgraded the axis over the contralateral right common femoral to 7 French, and heparin was administered, of course. And then we proceeded with crossing the CTO. Using a 0.18 CXI catheter, and we had to escalate wire up to a Stato 40. We were successful with crossing the CTO. We then dilated with a 2.5 coronary balloon. And at this point, we proceeded with treating the inflow first. Remember, the patient had severe iliac and common femoral artery disease. So first, we started with the common femoral disease. It was almost approximated at 80% stenosis. We used the shockwave balloon here. We used 6 cycles of the shockwave at the common femoral 6x60 balloon. Followed that with a drug-coated balloon from Medtronic. We then went a little bit more proximal to the iliac artery. We treated that with first dilated by a 7x20 regular balloon, and followed that by a Visipro stent 9x17, dilated at 12 ATs. At this point, the patient has severe disease, so now we opted to treat his outflow portion. With his severe disease, with the severe calcium, with his lung lesion and CTO, one of them actually would qualify him to the JET Ranger study. So just a short introduction about this study. It's a prospective randomized study, 2-to-arm randomization. 2 goes to the atherectomy and DCB versus DCB alone, and this is primarily run by the foundation with Dr. Shammas being the PI. So after randomization, the patient was randomized to the Ranger arm. So he gets a DCB balloon. We used 2 balloons, 6x100 over the distal POP region. You can see that in the images here in tandem fashion. Unfortunately, after the DCB, we noted some recoil at the distal POP, distal SFA, and distal popliteal. I don't have images for that. So at this point, we decided with this severe disease, we don't want to stent, so we were going to use the TACK endovascular system. So the TACK system, just shortly, it's basically, you can imagine it as many stents, 6 millimeter in length. It comes over a 6 French axis for this system. And the endovascular endovascular TACK for above the knee carries 6 tacks in it. You can see that in the catheter here on the right, between those 2 indentations where the small tacks are found. As you pull back the catheter, you precisely deploy those many stents at the areas where you feel or the operator sees there might be a dissection or a significant recoil. So this is the final angiogram. We dilated post-TACK deployment. We used 6 tacks. We dilated with a 6 millimeter balloon. You can appreciate the good flow to the foot, 3 runoffs. no residual embolization distally, and no residual, the residual stenosis less than 30%. This is a post-TACK image at the FEM-POP segment. It's hard to appreciate the tags on angio. It's it's very minimal stents, very minimal scaffolds that it's made of. Finally, as we pulled back, the patient still had disease in his right iliac, and that was the access site from the right common femoral. So we dilated with a regular balloon, and we used a 10 by 57 Visopro stent. And you can see that in the image on the right. The first image is deploying the stent. The last image is showing the 2 stents. So finally, the take-home message from this case, so in a severe multi-level, severely calcified disease with a CTO, the use of shockwave, DCB, and TACK system have avoided excess stenting. We only had to stent the iliacs, which are usually stented in most of the intervention. Shockwave, again, and the calcified common femoral had good results, and with the TACK system, we left minimal scaffold behind. Thank you.
Perfect, nice case. So what's the recommendation on using this system? I have to say I have not used it, so I don't have experience with it. Just flow limiting dissections, and when you use it, can you use just some of the stents and not
Definitely.
all of them? And
yes.
Can you comment on that for people like me who have not used it?
Yeah, so to my knowledge, so this system, there is it's approved for above-the-knee intervention, and the catheter carries 6 tacks with it. Of course, the operator can decide to, if he wants to use only 2 out of the 6. And again, those tacks can dilate from 3.5 to, I think, 6.5 millimeter. So it accustoms, as you said, areas where you see limited dissection. Instead of putting a long stent there, you can use maybe 2 tacks. Where you see a recoil, again, you can use that. And there was a study in 2016, I think, Dr. Mark, the TLR rate at 1 rate was 89%, single arm study. So,
perfect.
Yeah.
Has anybody used these? Comments on it?
I just am interested in knowing how does the cost add up when you're using shockwave, TACK, and balloons, and does the procedure pay for itself, or?
No, that's an excellent question. Always cost effectiveness is, I mean, what we always think of. I think at this point in our lab, we are enrolling in the shockwave registry. So I don't think there's any cost directed to the patients. So this is part of the shockwave registry for that balloon. I know it's almost $1,500 in price. And DCB also, I agree with you, adds extra cost to that. But
and he was in the Jet Ranger, so they paid for the...
He was in the Jet Ranger, for the Ranger balloon.
So everything
so that was covered, taken care of.
All right, well, perfect. Thank
Absolutely.
you very much.
Thanks.
Great case.